So the question with respect to the choice between time-limited and continuous therapy is challenging because it depends very much on patient-related factors. With respect to factors for the CLL in general, where we know, or we have seen that now also with the GAIA study, that particularly patients with a mutated IGHV status who have an excellent prognosis when they achieve deep undetectable MRD rates with a long persistence of these remissions, that this is probably the patient population which benefits most from time-limited therapy. Therefore, I would, in general, for patients with mutated IGHV status without any other adverse risk factors, I would recommend more for time-limited therapy than unlimited therapy. On the other hand, we have high-risk patients or very high-risk patients as patients with TP53 operations, probably also patients with a complex karyotype. So we do not yet have data from a head-to-head comparison, but at least doing cross-study evaluations, it could be that those patients benefit, at least for the remission duration, more from a continuous treatment with the BTK inhibitor. And then we have the group in between, patients with some adverse prognostic factors, for example, patients with an unmutated IGHV status. And this is the patient group where the question is really completely open. And here, I think we can discuss that with the patient. We don't really know so far what is the best treatment option here. The CL17 study from the German group and other cooperation partners will show here in a couple of years the results. I think it has to be discussed with the patient's circumstances. Venetoclax plus obinutuzumab requires a lot of blood controls initially during the first weeks. This might be difficult for patients who are still working, and therefore for those patients, continuous treatment with BTK inhibitors is much easier to combine with their normal life, and then the venetoclax obinutuzumab treatment with ramp up. On the other hand, some patients wish to have a time-limited treatment coming off treatment, which could also be beneficial with respect to the recovery of the immune system, in contrast to the continuous therapy. Therefore, I think there are several factors to be discussed. Also, patients' access to the next treatment center, comorbidities, as cardiac comorbidities, platelet inhibitors, for example, and according to those, physician and patient together should make a decision for one of the two treatment options. I think what we all have to admit is that for really long follow-up, we also have to consider response to the next line of treatment, what we call PFS2. And here data are not yet available from large cohort of patients.